This is the case of Shep. Shep is a 7-year-old mixed-breed male castrate canine that has a chronic history of bilateral otitis externa. This has been unresponsive to conservative therapy with long-term antibiotics. Rods and cocci were present on cytology from swabs of the external ear canals on both sides. On physical examination, there is a moderate amount of debris seen within both external ear canals, and the walls of the external ear canals appear to be reddened and inflamed in appearance. Both ear canals are also moderately stenotic. There is a rounded soft tissue mass that measured approximately 4 millimeters in diameter seen deep within the right external ear canal on video endoscopy. Radiographs obtained previously showed mild occlusion of the external ear canals. However, the region of the tympanic bulla and remainder of the skull appeared to be normal on the plain films. A CT examination of the tympanic bulla was planned. On this video clip, note that the region of the tympanic bulla or middle ear on both sides is air-filled, and the medial and lateral compartments are symmetrical and well defined. There is no evidence of bony lysis or bony thickening. There does appear to be a moderate amount of soft tissue opacity seen filling the external ear canals on both sides, slightly more severe on the right side. On these static images, again, fluid or soft tissue opacity can be seen within the external ear canals. However, it appears to be limited to the external ear canals, as the middle ears appear to be normal and air-filled. A quick review of anatomy shows the tympanic bulla in this region, which in this particular case appear to be normal, symmetrical, and air-filled. In Shep's case, the external ear canal is filled with a fluid or soft tissue-like opacity, which is causing occlusion of the external ear canals. Again, this is slightly more severe on the right side. This is the region of the inner ear, which is surrounded by bone. This arrow points to the location of the tympanic membrane, which is the boundary between the external ear and the middle ear. Note that the fluid opacity is external to the tympanic membrane, indicating that most likely the tympanic membrane itself is intact. This very faint osseous division is seen between the medial and lateral compartments of the tympanic bulla. This is a close-up view in transverse orientation, again showing the fluid opacity being confined to the external ear canal, with the middle ear being normal and air-filled. In summary, Shep's Röntgen signs include bilateral fluid opacity or soft tissue opacity deep within the external ear canals on both sides. There is partial to near total occlusion of the external ear canals secondary to the opacity within both sides. The tympanic bulla appear to be normal and air-filled, and there is no evidence of lysis or thickening of the tympanic bulla. The tympanic membranes also appear to be intact. Our suspect diagnosis in this particular case is bilateral chronic otitis externa. There is no evidence of abnormalities associated with the region of the tympanic bulla, and therefore no evidence of otitis media or bulla osteitis was present. Both ears were flushed, and samples of the fluid was submitted for cytology, culture, and sensitivity. The mass lesion seen within the right external ear canal was also removed and submitted for histologic analysis. A resistant Pseudomonas species was cultured from both ear canals. The Pseudomonas was resistant to most antibiotics except for a few, including amikacin. The overgrowth of Pseudomonas was also felt to be responsible for prevention of growth of any other bacteria that were seen on cytology. The growth within the right external ear canal came back as an inflamed otic polyp and was felt to be secondary to chronic otitis. No evidence of neoplasia was seen on either side. Shep was then placed on antibiotics and steroids, as well as topical antibiotics and steroids within both ears. Shep did extremely well.